The Tua Tagovailoa injury. What is it? How did it happen? What's going to happen now? And what's going to happen in the future? Stay tuned to find out.
Of this first half. Comes out throwing. On the run.
Hey everybody, Dr. Chris, orthopedic surgeon and sports medicine physician. Welcome to my channel, your favorite source for information on broken bones and other things.
That's a little doctor joke we like to make around here.
So today we're talking about Tua Tagovailoa and the right hip injury that he suffered in a game against Mississippi State. Tua Tagovailoa was injured in the second quarter of the game against Mississippi State on November 16th of 2019. He was tackled from behind while scrambling from the backfield by Mississippi State player Leo Lewis. Tua had previously injured his ankle prior to this game, but he was listed as the starter and he was able to play reasonably well during the first two quarters. At the time of his injury, Alabama had built up a sizable lead. Immediately after the tackle, Tua looked to be in pain and he was unable to weight bear. He was helped off the field and it was reported that he was in extreme pain while being transferred in the locker room. He was immediately taken by ambulance to a local hospital. From there, he was subsequently airlifted to the St. Vincent Medical Center in Birmingham, Alabama with a quote-unquote very serious injury. Later reports revealed the diagnosis and stated that he would be taken to surgery imminently. So this brings us to the questions. Question number one. What injury did he suffer? Tua is reported to have suffered a posterior hip dislocation with a posterior wall fracture. This leads us to question number two. What is it? What did I just say? A posterior hip dislocation describes the injury where the head of the femur pops out the back of the acetabular cup. The acetabulum is the cup portion of the pelvis. So the posterior dislocation means that the femur or the femoral head has now come out the back of the cup. That's the dislocation part. A posterior wall fracture means that the portion of the cup which makes up the back wall has been knocked off during the dislocation event. So he suffered a posterior dislocation where the head came out the back of the cup, but on its way out, it knocked off a significant portion of the back wall of the cup. That's a posterior dislocation with a posterior wall fracture. A posterior wall fracture is, in fact, the most common type of acetabular fracture, and this occurs in approximately 50% of the cases of acetabular fracture. And as I stated, this is a fracture that involves all of the articular surfaces of the posterior or the back wall of the cup. Usually, this type of fracture is associated with motor vehicle collisions, and it is caused by a person's knee hitting the dashboard and knocking the femur out the back of the cup. So, question number three, how did it happen? Well, if we look to the video, we can see that as Leo chased Tua down, he tackled Tua from behind. As Tua fell forward with the tackle, he landed on the ground while his right knee was in a flexed position. When he landed on his knee, he landed with not only all of his weight on his knee, but he also landed with all of Leo Lewis's weight, which if I'm to take the information from the Mississippi State roster accurately, then that would be an additional 245 pounds. So he landed with all of that weight on his flexed knee. And unfortunately, all of this weight caused the femur to act like a nutcracker and to punch through the back wall of the acetabulum, knocking the posterior wall off in the process. So yeah, that's how that happened. Just about like that. And I can venture to guess that it didn't feel too good either. So moving on, question number four. Now what? Well, a posterior dislocation with a posterior wall fracture is actually a very, very serious injury. And this is something that will require reduction in less than 6 hours. What is it that I mean by that? Well, when the head punches the back of the acetabular cup and the posterior wall off, oftentimes the head remains out of the joint, outside of the joint. And that's not really a good thing, because there are a number of neurovascular structures that are around this area that can be impacted or damaged, and the cartilage, which is on the femoral head, is outside of the joint and it needs to be back inside the joint. So all of these structures are displaced from where they are normally found, and they need to be reduced or put back into their anatomical locations. After the hip has been reduced back into the cup, then the patient needs to have traction applied. And typically, this will be skeletal traction. What does all that mean? Well, usually this injury is unstable, and the hip doesn't really want to stay inside the hip joint after it's been reduced. So in order to make it stay there while the patient is awaiting surgery, we need to hang weights, traction. We need to pull on the leg to make sure that it stays where it's supposed to and not outside of the joint. If we only have to use a small amount of traction, then sometimes we can just tape weights to the leg and hang the weights off the end of the bed. But if the patient requires a large amount of traction, or the traction needs to be on for an extended period of time, then we will typically use skeletal traction. And this just means that we're going to drill a pin through their leg, and then we will use an apparatus to hang the weights off of the pin so that we can pull with greater force or more weight to allow us to keep the hip in the position where we want it, inside the joint rather than outside of the joint. After he has been placed in traction, we need to then perform a CT scan, computed tomography scan. And this is basically a very fancy x-ray where we take hundreds of x-ray shots in a short period of time so that we can determine exactly the orientation and position of the fracture fragments. We also want to make sure that there are no fracture fragments inside the joint where they're not supposed to be. In addition to this, we want to look for associated injuries because this type of fracture is often found with a number of other injuries. Remember I told you this is a very serious problem? I was not kidding. This is a very, very serious injury. Some of the other problems that we might be looking for include urinary or rectal injuries, sciatic nerve injuries, other associated fractures, and further down, posterior cruciate ligament injuries of the knee. We may need to perform additional x-rays or CT scans to better delineate the fracture and for surgical planning. In rare circumstances, if the posterior wall fragment represents less than 30 to 50% of the posterior wall and the fracture has been demonstrated to be stable under fluoroscopy, then we can treat this fracture non-operatively. However, imaging must show that there are no incarcerated fragments within the joint. And that just means that there can't be any little crumbs inside the joint where they might get crushed and scraped on the cartilage by the femoral head. We don't want that. There are a number of indications for surgical treatment of this type of injury. Those indications include, number one, incarcerated fragments in the joint. This just means that there are crumbs inside the joint in between the articular surface of the cup and the head. And you don't want that because they'll scrape the cartilage and they'll cause premature osteoarthritis after the injury. Number two, a hip fracture that cannot be reduced by closed means. If you can't get it back in before you open the skin, then you must open the skin in order to perform that reduction under visualization. Number three, hip instability has been demonstrated under fluoroscopy. And this just means that under a certain type of radiographic assessment, we've seen that the hip goes in and out of joint without any sort of stability of the hip joint itself. In other words, the fragment that has been broken off is required to hold the hip in joint. And finally, number four, if the posterior wall fragment is greater than 50% of the posterior wall, then surgery is indicated. Now, generally speaking, because this fracture is in the back, this is typically something that we fix in the prone position, meaning that we have the patient lay down on their belly with their buttocks in the air, and we operate on this patient from the back. This is usually done on what is called a radiolucent table. This is a table that will allow us to shoot x-rays through it, and we do this with the assistance of fluoroscopy, which is a certain type of x-ray. We usually approach the pelvis through what is called a Coker-Langenbeck incision. There are a number of different implants which can be used for the fixation of this fracture, and those implants include lag screws if the fracture fragments are very large and non-comminuted, meaning no potato chips. A reconstruction plate and screws if the fracture is comminuted, meaning lots of potato chips and crumbs in the joint. And finally, a spring plate, which is also used if the fracture is comminuted. Plate and screw fixation is favored over screw fixation alone. And occasionally, bone graft may be required if the fracture fragment is especially impacted, meaning that when the head went through the cup and punched the fragment off, the fragment was actually compressed down like styrofoam. If there is significant compression of the articular surface of the fragment, then bone graft will be required behind the fragment to help build the articular surface back up. After surgery, when the fragment has been fixed, then a post-operative CT will be required in order to assess the joint itself to make sure that none of the screws used during the operation to fix the fracture fragments have actually penetrated into the joint, where they might scratch the articular surface of the femoral head. So finally, question number 5. What is going to happen in the future? Well, obviously, I have no crystal ball, but there's a few things that I can tell you about this fracture and what I can expect for Tua in the future. So number 1, this fracture is associated with a very high complication rate. That's unfortunate for Tua. Some of the potential complications include a sciatic nerve injury from the trauma itself or sometimes from the surgery. And who cares about the sciatic nerve? Well, anybody who's had lower back pain and sciatica, they'll tell you that the sciatic nerve is important. But basically, the sciatic nerve is the major nerve that travels down the back of your leg, which powers all of the muscles on the back side of your leg. Everything, all of them. So it's an important nerve and you really need it. And if it's injured, that's gonna suck. This fracture pattern is also associated with a loss of fixation. This just means that when we put screws in this area, it's very, very difficult to obtain very good purchase. And sometimes the screws will loosen before the fracture has actually healed. And sometimes the plates will come loose and the fracture will move. And that's not really good. Don't want that either. Also, this fracture is quite often associated with post-traumatic arthritis in like 20% of the cases. You know, like 1 in 5. That's also not very good. Don't really want that either. And finally, this fracture pattern is associated with a high rate of non-union. These fractures tend to not heal in a large amount of cases. And you really do not want that for Christmas. Tua doesn't want that. So in the end, what does this all mean? Well, let me wrap it all up for you. Tua Tagovailoa is expected to be, let me rephrase that. Tua Tagovailoa was expected to be a top 5 pick in the 2020 NFL draft. He was expected to be a top 5. Top 5! Top 5 means big money. Big money, big contract. Now, the draft and his future in football are in question. Basically, we can expect healing of this fracture if all goes well and according to plan to occur over a period of 6 to 12 weeks after he has surgery. After that time, we can expect that he will undergo rehabilitation for at least another 6 to 12 weeks, probably around 3 months at least. If he has no complications after this initial period of rehabilitation, then he will be able to begin training and he will be allowed to engage in impact activities. That just means he'll be allowed to run after probably 6 months. And if he is even able to play football in the future, in my opinion, I will not expect him to be back on the field for at least 1 year after this injury. So today we've been talking about the Tua Tagovailoa injury. Be sure to like, share, and subscribe. And as always, that's been a word from Dr. Chris, not your everyday ortho.
Just a flesh wound.
you.